Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I am joined by one of my favorite nurses of all time, the illustrious Kali Dayton. Thank you so much for joining me today.
Thanks for having me, Rosa.
You are such a powerhouse. I am so excited to get to just spotlight the amazing work that you are doing that is transforming critical care across the world, and that is not an exaggeration. Sometimes I get excited and people think I'm exaggerating. There's no exaggeration here. Kali Dayton is a critical care nurse practitioner. So let's talk about what you do consulting-wise. When you come in as a consultant, what are you doing?
As a consultant, I train ICU teams to become Awake and Walking ICUs, which means that we are having a full overhaul and transformation of their sedation, delirium, and mobility management to have full mastery of the ABCDEF bundle.
Love that. When you had me on your podcast a couple of years ago, we talked about the ABCDEF bundle. And when I worked stroke ICU, that was really important to us because we had to make those neurological assessments and we had to keep those patients as optimized as possible and prevent delirium because we didn't need additional things messing with their mind because we were looking for stroke activity. So that's always been really important to me since I learned about that. And I really am thankful for the work you're doing. And you actually came and consulted in Louisville, Kentucky, and a mutual friend then introduced us. And I'm just so thankful for the work you're doing, especially because I was in the ICU before COVID. And then those ICUs that were awake and walking before, a lot of those people who were trained in it left the clinical practice. And so the people who were left there coming in and learning were learning how to prone patients, but not necessarily get them up and walking.
Yeah.
So it was a whole new population of people that need to be educated on why this is so important and how this works practically. So tell us a little bit about how your podcast got started and grew to now being one of the top critical care podcasts in the world.
Yeah, that's fun to think of it that way, considering the roots. So I started my critical care journey as a nurse in an Awake and Walking ICU back in 2012. So I didn't really know much about the ICU. And so they brainwashed me to think that it was normal to have patients awake after intubation and even walking hours after or within, a day or two. And that was the norm there. I never questioned it, right? When you're new, you just accept everything that you experience and are taught and are mentored to do. And that was my reality.
Mm-hmm.
After a few years, I became a travel nurse. And when I went to another ICU, in fact, I ended up going to 10 other ICUs, I was shocked initially to find that that was not the norm in these other ICUs, that the norm, in fact, was to automatically put these patients into medically induced comas. And when I would ask questions about it, they would basically say, they're intubated, they have to be sedated. Why would you ever let them wake up? Why would you ever get them up? And I was the only one that shared this experience or perspective. And I didn't know why we did that in my first ICU. And I erroneously believed that what was normal was benign. So I thought, well, if everyone else is doing this, it must be fine, right? I'm here to have new experiences and to learn. And I'm not in my old ICU. Maybe these patients are different. And so I just did what everyone else is doing for the next 2 years. Then I returned to my original ICU in Salt Lake City, Utah, when I went to grad school. While I was traveling, I saw a lot of patients have tracheostomies, go to LTACs, be very dependent on all of our care, be there for a long time, be very altered. All these things that just were different than what I'd experienced in Awake and Walking ICU. So here I am experiencing this again, being like, there's this huge contrast. Why are we the only ones to do this? I was doing float pool in that area. And I was almost getting whiplash between how we care for patients and then Awake and Walking ICU. And then I'd go to another ICU and they would barely let me take sedation off, let alone get them up. And I was so confused. And this led me to look into the research. And I realized that there was a lot of research on this aspect of care and that we were doing a lot of harm by sedating patients and leaving them in bed. And we knew it. Well, the research knew it. The evidence, the science knew it. But I didn't know it.
Let's remember, what is the gap in years between research and practice? Isn't it like
15?
Yeah,
so 15, 17, yeah, something like that.
Before
And, some of this research, my home ICU put some research out in 2007 showing that it was safe and feasible to walk patients who are intubated on the
So they
ventilator.
were leading the research.
They had, yeah, and they had inspired a lot of, like, ICUs like at Johns Hopkins and Vanderbilt to do the same. My mentor, Polly Bailey, who was the nurse that established that ICU and that process of care, she'd gone to these ICUs back in the early 2000s to teach them to do it. But I was never taught that. And I thought if I had known this information, I wouldn't have done this. I serendipitously ran into survivors on a plane ride online, and I was hearing from them what it was like to be sedated, the hallucinations, the trauma, how their lives were completely different, not because of the critical illness itself, but because of the delirium, the ICU acquired weakness. The thing that came to ICU from was mostly healed, but now they're cognitively and physically and psychologically very altered. And so I thought I would never have done this. I knew how to keep patients awake and mobile. I just
Mhm.
didn't know why we were doing it. And I didn't know how to advocate for my patients. And I know these wonderful people that I worked with and all these other ICUs would
Yeah,
never intentionally harm a patient.
exactly.
Like, I had fallen for some of the myths that sedation was sleep, that it was more comfortable. And I thought they genuinely believe that. That's why they do it. And they've never experienced what it's like to let someone wake up after intubation and how much easier that is. And so I started the podcast Walking Home from the ICU to give a voice to those survivors because they're the true educators, they're the most compelling. And
Yeah.
then also to give a voice for my colleagues to prove, to back me up that we are actually doing this here. These patients are actually sick. Um, to give a voice to the researchers. You know, they've produced all this research, but somehow it's not reaching the bedside clinicians.
Mhm.
And then COVID hit, and I assumed that no one would really care about the podcast, but it ended up being very relevant to the podcast. So
Yeah.
I continued diving down all these rabbit holes, exploring the research, how to apply it, what the barriers are, why aren't we doing the things that we know will drastically increase patients that will drastically increase patients' chances to survive and thrive. And that's how the podcast came to be.
And was it just dramatically adopted by everyone who heard about it?
You know, I think when I started the podcast, I really oversimplified it. Working in that Awake and Walking ICU at that point, they had done this for over 20 years. And so it was a well-run machine. Everyone knew their part.
Mhm.
It was part of their skill set. It was just the routine. And so I essentially was saying, just don't start sedation, get them up. It's easier, guys. Okay, bye. And I really thought the podcast would be like a few episodes and be done. During COVID, people were asking me to do ground round presentations for their teams. And so here I was. I only had like 45, 60 minutes to say, hey, this is actually hurting patients. Here's the reality of what we think is normal and good. Do it the exact opposite. Do it this way. Look at my COVID patients. Bye. And I probably caused some moral injury, right? Like this ice water dumped over their heads, switching their perspective of what was helpful for patients and what was best practice to something totally different. But they
Yeah.
didn't necessarily have the tools, the skills, the knowledge, the teamwork, the
Mhm.
workflow, all these things that make it possible to practice that way. And so
Yeah.
after probably a year or two doing that, I realized, okay, if I can just go to them, if I can just go to their hospital and show them with their own patients, they
Mhm.
will believe it more, they'll see it more. And then it turned into, okay, let's practice in simulations training. Let's lay a foundation of webinars where we can really lay key knowledge that plays into critical thinking and optimizing, customizing care for each patient.
Mhm.
And then practice applying that and all these skills that we need as a team, everyone together. We're going to practice how to work as a team. And then we can start doing this on our real patients. And now I can provide support ongoing to help them learn as they go how to really do this. But it was not as simple as I thought it was. Many revolutionists, that's what I call podcast listeners, people that are out there at the bedside, they're able to go and change things. I mean, they can make a big impact on their team. They make a big impact on their own patients. They apply this, they figure it out. It's amazing what they've accomplished. But for the whole team to be bought in and be willing to transform everything, like some of
Yeah.
the pillars of their environment, which are sedation and immobility. It takes a lot more than one or two people saying, hey, I heard a good podcast. You should listen. So
Yeah.
that's how I became a consultant.
And it requires interdisciplinary cooperation. Like I'm gonna imagine the physicians and other providers who are writing the orders would probably be easier to get buy-in from. because you could just show them the evidence from the literature?
It's just every team is different. Every provider is different. The barriers are different. So I find with providers, a lot of times they're like, yeah, the evidence supports that. We support it. And they stay in the wings and give a thumbs up.
Which
That's
is
very
great because you don't want them to be a barrier.
well, they don't intend to be a barrier, but then they can be later. So they don't participate in the webinars or the simulation training. And then they come on the unit and they see sick patients sitting up in the chair on the laptop, and they panic because that's not what they expected.
Oh,
But you kind of have to understand the history of the bundle. Initially, research from the 90s and the
right.
early 2000s said, hey, turn sedation off every day and see if they can get off the ventilator. So awakening and breathing trials, and that improved outcomes. And then they realized after these researchers went to my home ICU, oh, okay, that's good, but it's even better not to even start in the first place, to get them up right away, to do all these things. But the mentality is still stuck in these awakening and breathing trials. So when physicians say, yes, the research supports that, it does, but the physicians themselves don't understand the research and they don't understand what this bundle, all these interventions are supposed to create, what we're working on. They don't really have the expectation that every patient possible be awake and texting on their cell phones while intubated early on. So they automatically still write these sedation orders. They don't follow up. They don't take a lead. They're more scared of mobility than the nurses are because the nurses are more
Oh,
trained, right?
boy. Well,
But if they haven't attended training, they're like, I don't know. I don't know about that because I've never learned it, but they
mhm.
miss the chance. So it just depends on the culture and the environment of the team.
So have the rehab teams and the respiratory therapy teams that are integral parts of actually physically making this possible with the nurses, are they resistant at all to changing practice like this, or would you say they're more receptive?
Physical and occupational therapists are much more receptive, right? Because they're the ones having to clean up the mess that we create, essentially, because we sedate patients and then oftentimes we don't let them come in and work with patients until they're off the ventilator, until they're less sick. Um, their vasopressors are off and all these things. But by then, now you've got these adult bodies that can barely hold their own head up. And nurses don't see it as their job to rehabilitate them. It's going to be the rehabilitation department. So they come in now, they have the literally heavy load
Mhm.
of trying to rebuild the muscle and the capacity to sit, stand, walk, and swallow. So they get it. And they love the idea of preventing that harm and not having to be the cleanup crew every patient. But it's a whole new skill set for them. This is a different focus. It's one thing to be, setting someone up when they have a tracheostomy. It's another thing to be maybe getting someone to walk when they are intubated and on
Mm.
high vasopressors and high ventilator settings and they're critically ill.
Or ECMO.
Or ECMO, right, and all these other devices. And so it's just a new learning curve, but they're totally capable of it and willing to. They may learn this in a class, but then they go to the IC, their own ICU, and they're like, yeah, let's do this. The nurses won't let them in the room. The physicians won't write the orders. The sedation's running. So they've never really had a chance to actually practice that way. And so now's their chance. Respiratory therapists could be very scared. They've never learned about this. This is all they've ever known. So similar barriers to the nurses, but it's really fun to watch them start to shine, right? Because in reality, they, as the ventilator experts, should be the ones
Yes.
initiating mobility because that's what gets patients off the ventilator. So once they learn those foundational concepts and they start to actually see it in action and develop that skill set and own it, it's really fun to watch RTs become strong leaders in the ICU.
Yeah. Ugh, I just absolutely love it. Like I love it when teams work together. And I know there is just a lot of resistance. And like I believe you said at one point you got reported to your state board of nursing over the podcast, right? Is that what happened?
Yeah, my podcast, social media consulting, everything triggered um, a supposedly anonymous nurse that had created a lot of really funny memes, primarily about sedation. And so she had a following of like 60,000 on Instagram. And some of, I think, my followers, some of these revolutionists were commenting saying, hey, I don't think you know what you're joking about. I don't think this is as funny as you think it is. It's really not good to be joking about causing increased patient harm, trauma, disability, and mortality. And that they would tag me in it. They'd say, check out Dayton ICU Consulting. She gives a lot of shocking information about this. But instead of being open to learning, she was very defensive. And so I ended up being the inspiration for many of her next memes and videos. It was supposed to be a personal attack, but, we can all recognize that this is rooted in ignorance and fright. It's hard to look at what you've done from that last 12 years of your career and realize I harmed patients.
Yeah.
That's painful. It takes a lot of humility. It's scary to consider doing something different. It sounds crazy if you've never heard of it, experienced it.
Mhm.
I've had to look back at my own time as a travel nurse and realize, yeah, I hurt people. I
Yeah.
did the wrong thing. I didn't mean to, but intention doesn't change outcomes, right? Like it is the reality. So,
Matter though. Your intention does matter. And you did.
right. It didn't change the fact that that was the care provided to those patients, even if I
Yeah.
meant to do well by them. But we just feel that prick of guilt and we use that to look forward and do better next time. But yeah, she had a army of nurses that were trying to discredit this, but it just inspired me to put out more evidence, more information, try to make all this research more digestible and accessible to those kind of nurses who are not going to the conferences, who are not reading their research. So
Yeah.
it was uncomfortable that she was taking my license number and plastering it everywhere with the email address for the board of nursing. But the board of nursing just, laughed it off. I mean, this is evidence-based practice.
Exactly. I was like, if anybody had a defensible position, it was you. Come on.
Yeah.
Yeah. And I love that you've used podcasting. And in this case, this was the raising awareness of people who weren't even listening to your podcast, who are learning about it on social media.
Mhm.
Even and now you've been making some more short form content, like little skits. I saw some of
Yeah.
those. Tell us about your favorite one of those so far.
Yeah, it's still so new.
Mhm.
It's uncomfortable, right? Like it's who wants to put on a really
Oh,
cheap
your
booty wig?
yeah, your big blonde wig is uncomfortable that you put on for these skits that you've been making.
Yeah, but I realized through the last 5, 6 years of teaching about this, academia is great, and it's great if you're in that environment and you're used to listening to information that way. But even our best academics are struggling to really apply this stuff at the bedside,
Mm.
right? Like when you say delirium doubles the risk of dying. Yeah, we're all concerned about that. That sounds bad. But when you have a patient with delirium, what do you actually do about that?
Right.
Or when you report delirium to your colleagues or someone reports it to you, what is the right response? Right.
Mm.
So yeah, I've trained 14 ICUs and I've been talking to thousands of revolutionists throughout the years. And I've heard all these stories. And I just think these scenarios demonstrate so much valuable lessons. If I love using case studies, that's why I
Yeah.
do simulations training. So I thought if we could just do something like that, that will actually show the errors that we're currently accepting as normal, the
Mhm.
cultural barriers, the interdisciplinary dynamics. So we have more, videos coming where real life scenarios where a physical therapist is like, hey, I'm going to go see this patient. The nurse is like, no, you're not. And then can't give a good reason. And the physical therapist says, yeah, okay, I guess that's the way it is. That's not right. But no one's really talking about it. So I feel like that's been my journey is what are the things happening that no one's talking about and calling people on that we're all suffering from? And
Mhm.
let's just put it out there, put it on the table, sift through it so we can fix it.
What is the furthest distance you have traveled to consult with a walking ICU?
The team that I've trained the first away is probably New Jersey. I
Oh, you
am
went to Brazil. That's what I was going
what?
for. I thought you went to Brazil. Did you not
No,
go?
that was Philip.
Philip went to
That's what-
Brazil.
Yes.
Daggum. Okay.
I'm planning on going to
Years.
Costa Rica this October. Um,
Rica.
I am working on finalizing plans for conferences in Saudi Arabia and the
What?
UAE this November, hopefully. So
That's
yeah,
amazing.
it's spreading. Yeah, it's
Mhm.
exciting.
Yeah, it is. And the thing is, this applies all over the world. If the pandemic showed us anything, is like that how much it does apply all over the world. And we need best practices to be disseminated and not wait another 15 to 17 years to get what's written in academic journals into our everyday standard operating procedure.
And we assume that it's a resource problem, and it's usually really not. My home ICU, we had very normal slash subpar staffing ratios. California would scoff and never accept the staffing ratios
Yeah.
that we had there. Yet we made it happen. And I'm
Yeah.
all about having a much support as we need, especially
Yeah.
as we develop these skills. It takes 5 people to sit someone up or get someone to the chair initially, but give it a month and it'll be down to 3. Give it 2 months and it'll be down to 2, right? But we need that support. But you look at other countries like Ireland, Saudi Arabia, they have 1-to-1 staffing ratios in their ICUs for
Wow.
nurses, and they're
Really?
still sedated. I hear from those clinicians, there's none of this happening. So it's not just staffing. You could have all the staff in the world. If you have the wrong information, protocols, culture, knowledge, you'll still keep harming patients. So it's been amazing to hear from teams. There are some teams in Brazil that do something like this. One team in Bangladesh, I did an episode with them where one of their physicians heard the podcast, looked at the research, and he was like, what do we have to lose? Almost all of our patients have pressure injuries. And
Right.
you have to see the videos of their unit. They're just beds that are essentially kind of like cots,
Oh,
stretchers. It's like
no.
lined up down a hall with these beautiful windows and beautiful view, but it's just they're separated by shower curtains, right? Like
Um,
they don't have anything that we have really. And they're like, well, everyone gets pressure injuries, so why not try it? And they started getting patients up. They like taught themselves how to do it. The physicians were the ones going in, hands on
mhm.
the patients with the nurses, being like, we are doing this together. And they developed such powerful teamwork. And
Yeah.
I saw such a huge contrast in outcomes. Like pressure injuries are almost not a thing anymore.
Right?
They never changed their beds. They never changed anything other than their sedation and mobility practices. And they have just amazing stories of patients that I wasn't even sure they could even keep alive in that area. And
Mm.
so even by our standards, these are critically ill patients, severe ARDS, that they have Awake and Mobile. And it's amazing. And they're so proud, and they should be so proud. So when people say we don't have the resources to do it, I say, well, are we using our resources well? Because we're actually putting a lot down the drain with
Mhm.
antiquated practices. And we could be much more efficient with what we have. And we could even gain more buy-in to get more, right? I've been able to get teams mobility techs by using the evidence to show that this is significantly financially beneficial for a hospital.
Mobility techs. So
Mhm.
people who are clinicians who are
Yes.
hired just specifically for this,
Some of them are not even clinicians. They're not even CNAs. They just get trained to do these
just
things.
for this.
Yeah.
Wow, that's
And
amazing.
yep, you can train them to be very autonomous. They're kind of airway traffic control, looking at the unit, being like, who's not out of bed? Why aren't they out of bed? We're here to get them out of bed. We're
Oh
helping.
gosh, that's
And
so
they just
cool.
hustle, right? I think it's a huge return on investment. So just because I didn't have that in my practice as an RN for 17 years and did it without it, I'm all about it, right? Why not? There's
Yeah.
so much more you can do. I'm all about having volunteers help push the wheelchairs, family members push the wheelchairs. I mean, we don't have to have, I've seen some of our largest, fanciest, best funded academic hospitals have amazing tracks down the hallway
Oh,
for walking slings and beautiful chairs and recliners for every single room and these beautiful windows. And yet patients are sedated and stuck in bed and those chairs sit and gather dust in the bathroom.
you
So
just said walking slings. What
yeah,
are you talking about?
you've got sitting slings, you've got like Hoyer slings,
Mhm.
and then you've got these slings that are kind of like, they're like a harness, think kind of like rock climbing, but it connects to the truck. So if they drop, they're in a sling. So all of these innovations are supposed to improve mobility,
Mhm.
decrease costs. But if we don't change our knowledge, beliefs, perceptions, practices, especially for sedation, we'll never use those innovations.
That's phenomenal. Do you think that this kind of revolution would be possible without sharing this best practice on social media?
That is such a great question because I look back to our earlier pioneers who I love and respect so much. They really did make a huge impact. The founders of the ABCDEF bundle, amazing researchers like Dr. Julie Barr, Heidi Engel. You've got Dr. Brenda Pun, who was a legendary nurse. I mean, they've just made a huge impact. They've been able to do so much. But you think about how different the world was back in 2012,
Yeah.
2000, even 2019. Mechanisms to disseminate information were pretty limited, right? If you didn't attend a conference,
Mhm.
you weren't really going to hear about it. And if they did attend a conference, you're crossing your fingers that that educator came back and shared that information with their team. But then did the team know how to apply it? Right.
Mhm.
And so AACN has been working on CSI. I mean, these organizations to help with quality improvement, but it's really hard to reach the individual. And so in the past, these kind of initiatives, but especially with the ABCDEF bundle, has been a train the trainer model. So when they did this huge study that was published in 2019, about 2016, they sent a few champions from each hospital, sent them to Vanderbilt for a few days, gave them some training, sent them back and said, good luck, go convert your team. Anyone that's worked on this, your face is even like, whoa. Because back then, they were using a lot of benzodiazepines. Patients were heavily sedated. There was no mobility. They were
Yeah.
so much further behind than many of our teams now. And so they made some progress, but they didn't really have a clear vision of an awake and walking ICU. They didn't know how to get there. And it's hard for a few champions to go around and like kind of whip everyone from behind to do things that they don't know why they're doing or how to do it.
Yeah, that's
But
not
they
gonna work out very well.
Yes, but they still made some progress, right? Like it was years and it was so hard, and they still, I mean,
Yeah.
from that study, they involved 68 facilities and over 15,000 patients. 7-day mortality decreased by 68%,
Well, okay.
right?
That's good statistics.
But only 12% of all of those patients, intubated or not, were actually out of bed bearing weight. So that's how much like every increment matters. We found
Mhm.
a dose dependent outcome. So the more months of the bundle, the more awake and mobile patients were, the better they did. And yet we still weren't like really disseminating to the community how to actually get there or what that should look like. So it's like,
Mhm.
okay, we're doing it because we take a little break from sedation every day. Because if you haven't worked in that environment, you've never seen a patient walk down the hall intubated. How
Yeah,
will you aspire to that?
right.
It'll sound crazy, but by social media, having patients and clinicians with authorization share those images and videos and the ongoing research, there's
Mhm.
a tide turning where
Yeah.
people are like, oh, I've seen that a bunch of ICUs. We've never done it here, but I believe it's possible. I'd like
Mm.
to do that. How do I do that? And so that's why I've just been scurrying to get the resources out there that those that want to make those changes can access them, bring it back to their teams, and actually make it happen this time. It's 2026. We're moving forward.
That's right. We're recording this in January, and where is a big place you're gonna be talking about this that nurses can come and hear you?
NTI, so AACN's NTI conference. I'll be part of an advocacy panel.
Yeah.
I'm doing some symposiums with teams around the country. There are lots of conferences coming up, APTA. But NTI is our big nursing hub, and I'll have a booth there as well. So stop by and chat
Yeah.
with me, and I'll have a whole video of talking about what this is about with pictures and images, and we can support each other. I'm hoping to get together an ICU revolutionist meetup so that people around the country and even
Yeah.
the world that are working on this can come and support each other because it can be a really hard and lonely journey trying to turn this around in the ICU.
Well, is that something you're trying to do, like, that you will be scheduling on your own or a meetup
Yep.
at
Yep.
NTI?
Yep. So follow me on social media. We'll have more information coming out
And your handle on social media is
at Dayton ICU Consulting.
there you go. Yeah, and then, that probably brings us to my billion-dollar question that I ask each
Mhm.
guest on here. You have been working so hard on something that I think will have huge financial savings and, prevention of expenditures, shortening length of stay in hospitals and things like that. Um, and if your answer has to do with that, that's fine. But if not, this is your chance to talk about something else you have a great idea about. So, Kaylee, if you were given a grant for $1 billion to meet a need that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
Well, I think this is a little bit underway, but if I could be the one investing that money, have more control over how it's done, using AI to really track patients' mobility. We
Mm,
should be knowing exactly what they were capable of when they come to the hospital, not just in the ICU, but throughout the hospital. And
mhm,
that should be a vital sign. So if
mm,
that changes, or we should have an alert going on being like, hey, this patient has gotten out of bed in 12 hours, what's going on? And have AI be able to really know that,
mhm,
that would save lives substantially. Within that, other things like making sure that every single patient has access to communication, which
mhm.
sounds crazy, right? Because we're both in this generation where we saw this huge overhaul of the iPads or the translators coming and being like every patient should be able to communicate in their own language, which is great, right?
Mhm,
But it stopped at the ICU. Well, it stopped at the ventilator. When patients come in and they get intubated, right now, there's no such expectation for those patients to be able to communicate.
right.
So I would take a portion of those funds and also put into communication tools. We
Is there a tool that you've seen that you feel like is really effective?
I do like VitaTalk. It's an app that can go onto any device. So if patients can't write, they can click on it. And so that helps a certain population of patients. I think there is a need to explore and do more research on how we can modify that for our neuro population, right? With the different kinds of aphasia. Then there are patients with things like Guillain-Barré, severe isochord weakness, when they can't lift a muscle and
Yeah.
point. That's a whole nother barrier. And so why not do eye gaze? Right now, I've never seen eye gaze in an ICU. I've heard of just a few having it available, but not really being used. So
Yeah.
that would be something I'd be very passionate about, is making sure that it's a standard, that ICUs are well equipped and actually use communication tools. So right now we ask things like, what is a patient's RAS? Meaning, how alert are they? I want to put at even higher priority, how do they communicate?
Mhm.
That should be part of our nurse handoffs, what we talk about in rounds. How are they communicating? Because if we focus on that,
Mhm.
that will help us see them as human. It will
Yeah.
help us avoid sedation. It will help us know and meet their needs so they don't get agitated and scared and all the things. And then they're going to be more available to be awake and to be mobile. And that will also save lives. We know when patients can't communicate, they're at much greater risk of malpractice and mortality.
Yeah. Definitely. And you mentioned eye gaze to help people communicate.
Mhm.
Is that what Stephen Hawking that uses that?
Uh-huh. Yes.
Yeah. Yeah.
My daughter uses it.
What? Your daughter uses it? Oh my goodness. That's amazing.
Yeah, so
So
she's taught me so
children.
much about nonverbal communication. Working in Awake and Walking ICU, we called it like gift of lips or gift of scribble, like instead of
Oh,
gift of tongues, like, oh, we can do a really good job of interpreting. And in truth, many to most patients really could write legibly because they were awake right away. The sedation didn't damage their muscles or their brain. But, if they did have delirium and now we're like, they're struggling or they're frail, there were times when communication was really rough even
mhm,
though they were awake. And I didn't know about eye gaze. And we did have patients with West Nile or Guillain-Barré that
mhm.
physically could not write. And
Right.
we would kind of try to read their lips. But now that I have a daughter who's nonverbal, she has mitochondrial disease. So she's kind of like presents like cerebral palsy or Stephen Hawking's, right? But she uses her eyes to communicate. I'm always like, why don't we have this available to people in the hospital
Right.
in these super vulnerable, potentially final moments of their lives?
Mm.
And communication doesn't matter. Well, they've got a tube. And to that, I say, just because they can't talk doesn't mean they can't communicate. But when it comes to animals, people say that all the time. Oh,
Mm.
my communicates with me all the time. Okay, what about your adult patient that just got admitted for pneumonia?
Wow.
Why not they? Why not allow them to communicate? Why don't you care about their thoughts and needs and wants as much as you do your dogs? Because they can't talk? Well, neither can your dog. So,
Mm.
anyways, I can go on and on about it,
Right. I think they're working on interpreting for dolphins.
but not patients in the ICU that are,
Oh. Yeah.
life and death situations, and
Yeah.
we
So
need to talk to them about
how
what they
does it
need.
work? Is it like a device the size of an iPad or like
Yeah, it's a computer that has a certain technology, which I think is starting to show up in some of our tablets and phones, the eye technology. So it reads a retinal reflex. So when they fix their gaze on an icon, so it'll have a menu. My daughter's has like 9 buttons at a time in a menu. So it'll be like places. And she has all these different options. And she has to look at it for like 2.5 seconds. You can program the timing. And you see this little circle start to form. And when it's complete, it clicks and it says, I want to go to Chuck E. Cheese. I want to go to the mall.
okay,
Yeah, she's super bossy. But that's that's hers. That's what's customized for hers. But if we made those like, I need to be suctioned. I need to call my wife. I'm in
right?
pain. And then they can point to which part of the body they're in pain at.
Oh,
There's so much that we could do. It's so much of this agitation that we see in the ICUs because they're panicked, they're scared. Oftentimes they have delirium and they
mhm.
can't communicate. They can't ask, who did I kill? One patient said that they thought they'd committed homicide and they were just panicked to be like, who did I kill? They thought they were imprisoned and that's why they were tied down. But if they'd been able to ask that, no nurse is going to know that that's what's on their mind. All they're going to see is that they're trying to, quote, self-extubate.
Mhm.
But really, they're
That
trying to
is
motion, I need to write. So that's such a passionate thing for me. And with, having my daughter and this whole journey we've been on and just having more exposure with the knowledge I have now, going to these hospitals and realizing, oh my gosh, they don't even have a pen and paper in the rooms.
yeah,
It's such a sore spot. So if we talk about humanizing critical care, humanizing medicine, humanizing healthcare in general, we can't
yeah,
do that without giving our patients a voice.
definitely. Um, thank you so much for taking your time out. We're recording this on a weekend because you and I just can't stop, won't stop.
Yep.
And I think that this is such an important conversation. I'm so thankful that we're continuing it and that you didn't give up when people are giving you a hard time on social media and trying to scare you off, because it's really worth it. And you are making a huge difference in people's lives. So I know you've inspired so many revolutionists, and I'm definitely, I don't feel like I count as a revolutionist because I'm not in critical care able to like do that. But,
You're helping spread the word.
you know,
Families, survivors, the general public, everyone needs to be jumping in and playing a part. So, absolutely, anybody could be a revolutionist.
yeah. And if you have been in the ICU or know someone who has, I believe there's a website that can support you called ICUdelirium.org.
Yep.
Is that correct?
Yep.
Yeah, and that's not your site. That's just a site for resources. But you have DaytonICUconsulting.com is the
Correct.
way to reach you, correct? Yeah. And then along the same vein, I have a book that I just put out called Speak Up, Start Now, encouraging other nurses in whatever their specialty is. If they see solutions and how those solutions need to be implemented, maybe new processes need to be completed, or maybe an injustice needs to be spoken out against. A lot of us nurses feel like we're not the most qualified. Maybe we need 20 more letters behind our name or five
Yep.
more degrees to be as valid as the most experienced people we know. But our experience is valuable. Your experience is what informed you and really shaped your message and the application of it. And so I'm hoping other people will feel empowered to lead in their area that they see solutions in. So Speak Up Start Now is available on Audible and Kindle. Or if you'd like a hard copy, you can have me come speak at your place in person and I'll be happy to sign it. So you can find that, contact me at nurserosaspeaks.com or find me on social media. I'm on all the platforms at Nurse Rosa Speaks, and I'll be happy to hear from you. If you've enjoyed this episode of the Nurse Rosa's Insights podcast, please like and follow wherever it is. And if you know someone who has $1 billion idea to transform healthcare, point them my way. I want to be knowing them. I'll have Kaylee's and my links in the show notes, and I'll see you in the next episode.